Hello, everybody here. All righty. This is Steve Levin, and I am your host for the next few minutes. So let's see, hopefully people can see my screen. Andy, Amanda, Mandy, can we all see my screen?
Yes.
Great. All righty. So my name is Steve Levin, and I'm the CEO of Connance. I'm going to see if I can click here we go. I'm the CEO of Connance, and Connance, we do some predictive analytics and workflow for providers around the country. And I'm joined today by Andy Bartley. Andy is, I'm going to make sure I read this properly. Andy is Senior Solutions Architect for the Health and Life Sciences Group at Intel. Intel works with providers and payers, life science organizations, government agencies around the world as a trusted advisor in the development and implementation of leading-edge collaborative care and distributed care solutions. Previously, Andy was Chief Operating Officer for NurseGrid. He's diverse experiences across both startup and Fortune 500 environments, focused on bringing new hardware and digital products to market. I think we all know Intel because we've all bought computers, whether we're Mac or Microsoft. They all are kind of Intel's sort of the foundation technology we all know and love around the industry. And so let me just personally, I've met Andy and known Andy now for a little while. It's going to be a great hour. I want to thank him for his time. I want to thank Intel for their investment in support of this conversation. And I know that these are time-consuming and can be complicated, but Andy's been very thoughtful over time, and I just want to thank you for him. So, with that, let me tell you what our agenda is today, and hopefully we've got an hour, 55 minutes or so, and what we're looking for is probably 40 minutes or so of some conversations that Andy sharing some of Intel's perspective, what he's seeing. I'll do a little bit after Andy to talk about what we're seeing and how those two things line up. And then at the end, we have some questions and some thoughts that we each have heard in different environments over the years. And we'll share on those, but we'll also open up for questions at the end. In the meantime, if people in the webinar have questions or thoughts as we go along, they just pop them into the chat bar. I think there's a chat room, and you can put them in, and we will either answer them along the way or save them to the end. So with that, I'm going to pass it on to Andy and let him start.
Perfect. Thanks, Steve, and thanks for the kind introduction. Thanks, everybody, for joining today, this morning, this afternoon, wherever you are. Look forward to the discussion a little bit later on. As Steve said, you know, at Intel, our health and life sciences team, we have an opportunity to, really work with healthcare organizations around the world. And one of the topics of late that's been of great interest, regardless of where you practice healthcare geographically, is around this idea of analytics and advanced analytics. So we're going to talk a little bit about that today. I'll present some sort of high-level perspectives on advanced analytics and healthcare. We'll talk about a couple of use case areas, clinical, operational, and financial, where predictive analytics can be applied. And then we'll talk about the importance of really, these projects and programs drive value when they're integrated into the workflow, be that the business process workflow, the operational workflow, the clinical workflow, but it's about operationalizing the analytics. And, from what we see, many organizations will get started with proof of concept programs around advanced analytics. That's happening today. But the ones that really get their investment back, the organizations that really succeed, have a laser focus and a really clear understanding of how to get that implemented into workflow. And sometimes they'll do it themselves. A lot of times they'll do that working with partners. And so we'll talk about that with Steve and some of the work that Connance does. So really glad to be here today and talking about this. First slide here is a quote, as you can see, from Vendel Washington, the previous head of the Office of National Coordinator for HIT. And, this really sort of sums it up. It's digitization has enabled us to have a more meaningful conversation around how to use predictive analytics to improve outcomes. So really the critical enabler in healthcare today that is making advanced analytics, predictive analytics, a hot topic of conversation, a critical area of investment, is the fact that healthcare now has data. If you look at just in the U.S., first U.S. hospital opened in 1751, Pennsylvania Hospital. 2011 to 2016, we had the majority of EMR implementation. So it's really, just in the past few years that we've overcome several hundred years of paper-based workflow and moved to more digital process. And now that these systems have been in place, largely speaking, for a couple of years, hospitals are finding that they have several years of data. And that's really the critical precursor to thinking about predictive analytics, is you need to have some data available, historical data available to build these models, because essentially these models, these predictive models, are using historic trends in the data to infer specific outcomes that will happen in the future. And so, there was a quote that I heard from Dr. Rick Lemoyne, the Chief Medical Information Officer at Sharp Healthcare, that touched on this. He said, healthcare organizations are looking for that digital dividend. We've invested significant amounts in the healthcare IT systems that we have today and the EMRs, and now we're looking for additional ways for those systems to derive value for the organization. So let's skip ahead to the next slide, Steve. Perfect, thanks. So it's like I said, it's a pretty pervasive topic, regardless of where you go. One of the first questions that we get is, how do we get there from where we are today? So, fundamentally, the idea of predictive analytics, we get it. The value seems clear. A lot of things that need to happen from, value seems clear to actionable projects. So we'll talk about some of those in just a minute. But, trying to understand and map out your current organizational capabilities today, where are you with the use of data today, and where do you want to go in the future, helps to have a roadmap. The great thing here is that predictive analytics is an achievable goal for any healthcare organization. And in fact, many healthcare organizations are doing predictive analytics today. Most folks are doing it are a lot of times doing it a little bit smaller scale. So when we're talking, predictive analytics today, part of what we're sort of inferring here is that organizations are using larger and new data sets to do this. Predictive analytics, regression, and Microsoft Excel has been around for a long time. But what's really new today is the compute technology and the artificial intelligence technology and the machine learning technology. They're enabling us to do predictive analytics on larger and larger data sets, closer and closer to real time. So really being able to operationalize these things as, again, going back to part of that workflow and building it in as part of the organizational DNA. Here we've got a pretty simplified 5-stage framework. This is something that, we at Intel have developed, similar to other frameworks you might see out in the market. This really comes from work that we've done hand in hand with customers across many different industries to help them optimize their analytics programs. We come at it obviously from a technology perspective, but it's really important to think about these projects holistically. It's a lot more than just the technology. It's the business process, it's subject matter expertise. And what we found is generally organizations follow this sort of maturity curve. So, starting off with descriptive analytics, what has happened, moving into where a lot of folks are today, business intelligence, what happened and why did it happen? And then you sort of cross this threshold to looking at what's going to happen in the future. And that forces a lot of really interesting organizational questions about how do we as an organization think about integrating data into the way that we practice daily and making it part of decisions and potentially changing workflow and changing the way we do things based on the results from predictive models. So they're forward looking. There's some technology changes that have to happen to make those more real time. And there's a lot of sort of business process change that has to happen to integrate predictive analytics. And really predictive analytics is one step on an overall journey. We're not going to talk a lot about this today, but certainly folks on the line have been hearing about artificial intelligence. For many organizations, predictive analytics ends up being that sort of first foray into different artificial intelligence technologies, mainly through the use of machine learning to build out these models and operationalize these models. And that, again, that builds organizational ability to start to move up that maturity curve towards more prescriptive analytics, and into the future, the use of cognitive type systems that can marry up predictive models with evidence-based guidelines to help with clinical decision support and next best action type of solutions, which we see the healthcare industry get into in the future. So Steve, let's jump ahead. Perfect. So talked about the adoption, the interest in predictive analytics. Let me back that up with just a couple of stats here from research that Intel conducted earlier this year with the International Institute of Analytics and Forrester. So the statistic there on the right, 86%. We worked with Forrester and looked at 300 different healthcare organizations in the U.S. and in China, and really asked them about their investment priorities with regards to advanced analytics going out into the next 12 months. And we did this survey last year as well. So we had 2016 data and 2017 data. What really jumped out from the survey results was that 86% of respondents, when we did the survey this year, said they either have a predictive analytics program in place today, that they're making investments in to further integrate into the business or to add new capabilities, or they'll have a predictive analytics program in the next 12 months. So 86% of respondents said this is going to be part of how we do business within the next year. That's up from 34% in 2016. So, what I talked about before, healthcare organizations are realizing, hey, we have the data. If we pick the right use cases, we have enough data to get started. And this is really critical. And it's going to become table stakes in healthcare is that we're able to optimize certain parts of what we do in healthcare based on using data. And then you marry that up with a survey result on the right that IDC took a look at the healthcare market. Data is a couple years old, but we're seeing actually a little bit of an uptick here about the amount of enterprise analytics spend going to predictive and prescriptive analytic solutions by 2020. So really seeing that now is the time and a lot of momentum behind this. And so what I want to do next, if you flip to the next slide, is just talk about a couple of areas where predictive analytics can be applied. And I'll say here that a lot of times I think from what we see, the clinical use cases get a lot of media coverage. So we'll talk about sepsis detection at Penn Medicine. That's a really kind of popular use case that comes out whenever there's a new sepsis detection model. And there's obvious reasons for that. I mean, we know that the healthcare, the use of analytics to improve outcomes is really core to the mission. But I would say that thinking through the operational and financial use cases for predictive analytics is really important as well. And for many organizations, starting with either operational or financial use cases can make a lot of sense. A lot of times those business processes, those workflows are not subject to some of the same constraints that they are when you get into delivering patient care. And so thinking about operational financial use cases can be a great way to sort of build that organizational muscle on how do we really think about integrating predictive analytics into workflow. The other thing is that, on operational financial, many times those use cases can have a very clear ROI model built around them. And that's really critical for an early advanced analytics program. You need to pick use cases where there's clear business value that's demonstrated by the outcome. And that'll help build organizational and executive support for the program, which will allow for future investment to scale that out and expand that effort and the advanced analytics program into other areas of the business. So let me talk real quickly about the sepsis detection use case here, so we can flip ahead to the next slide. So this is a pretty popular use case for folks that have followed Penn Medicine. They have a dedicated data science team, Penn Insights, and this is up on their public-facing website. Intel has done some work with Penn Medicine over the years, and really, kind of a leading-edge organization when it comes to the executive sponsorship they have behind this and the investments that they've made up front to build out data science resources internally that can help them address some of their key problems. So one of those is sepsis. I think folks on the phone will know and appreciate the magnitude of the impact that sepsis has financially, on outcomes, on mortality in the healthcare system. So it's a big problem in the U.S. It's a big problem globally. So it's one of those interesting, really meaty use cases to try to tackle with an analytic solution. At Penn Medicine, what they were trying to accomplish with their predictive analytics solution was, how do we get earlier notification of a patient that's potentially going septic? And there's a lot of data out there that supports the earlier you can intervene, the higher the mortality rate. So you're going to improve outcomes and also reduce the associated costs with those patients that ultimately do go into a later stage of sepsis. So if we flip to the next slide, what Penn was able to accomplish here looked really comprehensively across the data that they had. And I made the comment earlier about, one of the things that's new today with predictive analysis in healthcare is the size of the data and the amount of the data that these models are being built off of. At Penn Medicine, looked through an exhaustive list of features and ultimately came up with 500 different features that were used to train their sepsis early warning system solution. So with today's advances in computing technology, that's possible, right? But you're probably not building and running models like that in Excel as you might have done before. What they were able to determine with that was 85% accuracy in identifying those patients who ended up resulting in severe sepsis or going into septic shock. And what was really, really important here was that they were able to extend out that early warning 30 hours before that patient went into severe sepsis or a septic shock. So that gives the clinical teams, that gives the entire business the ability to really intervene and ensure that those patients don't end up in that condition. So increasing outcomes, like I said, and really reducing the costs associated with this. So, this is a great clinical use case of how predictive analytics, can be used with a focused team to really drive outcomes. So let's flip ahead to the next slide. So let's talk about an operational use case. And this is some work that Intel's done with Sharp Healthcare. So Sharp Healthcare, leading healthcare organization based out of San Diego, California. And Sharp, like many healthcare organizations, has rapid response teams. Some folks will call these medical emergency teams, but these are cross-disciplinary teams that respond to those medical emergencies, the different codes in the hospital. And Sharp has a very large campus. They've got different places where they deliver care. Many different floors in some of the buildings that they have. And so one of the challenges they have is, where do we allocate our rapid response team capital equipment and team members throughout the day? So, like many organizations, it's pretty reactive, right? The code goes up and the team gets together and they go respond to that patient. What Sharp wanted to understand is, would it be possible to build a predictive model that would help us identify those patients that are highest likelihood of requiring a rapid response team intervention in the next hour? So we worked with a couple different folks to put this together. Intel, you can see there, ProKarma was the data science partner, and Cloudera was the underlying data platform. But this is really an operational use case. How do we optimize our rapid response team operational response with the data? So in 10 weeks, we're able to build out a predictive model that was 80% accurate in identifying those patients that would have a rapid response team event in the next hour. Now, this is through a proof of concept. So those results are based on historical data. But taking a look at over 4,000 records, using about half of those to test out the model, found 80% accuracy there. What was interesting about this particular project, and I think it addresses a question that I get a lot, which is, do we have enough data to get started? This model was based off of 27 features out of a kind of a common EMR, and these were all structured features. So one of the things that folks will hear a lot is you need all of your data in one place, structured, unstructured, et cetera. And that certainly gives you the ability to improve upon models, to open up new use cases. But if you have an EMR today, there's probably potential if you kind of select the right use cases to get started with the predictive model. So with this, great kind of example. Sharp sort of started small with a pilot here, and is looking to kind of build this program with these initial results out into the future. But good initial responses and not a lot of time. In 10 weeks, being able to get a model pulled together with the clinical teams and the IT teams. So just really a great example of how when an organization cross-functioning rallies around these use cases, really interesting things can happen. So Steve, let's jump to the third. So final example I'll give here is in the financial space. So, many healthcare organizations are sort of struggling with an increase in days sales outstanding. The denied and underpaid claims coming back from insurers are going up. So it's getting harder to close out those open sales with the insurance providers. Today, a lot of organizations will sort of tackle this, either by let's go after the largest claims first, or we'll do a sort of a list based on just sort of age, and just sort of kind of work it through with blunt force to try to get those claims recovered. There's a lot of information in that claim data based on sort of historical knowledge about the claims getting paid out that can be used to build predictive models that can essentially help you segment out those outstanding claims and understand which of these claims do we have the highest likelihood of recovering, and what's the best way to recover those claims. And so, Christus Health is really struggling with this. They have a limited team that can be following up on these, that can be working it with insurance. And so instead of taking a bulk list, they want to understand, where do we put our team, where do we put our resources to really maximize the output? And here's some of the results. And so you can see from the work, and this is work that Connance did with Christus, taking a look out of the claims that they had, the high priority and low priority claims, which were effectively identified as the actionable claims out of their total population. And you can see there just over 12,000 of those were really identified as these are the claims that you should be going after. 14,000 of those claims were really identified as, hey, look, for various reasons, and it might be likelihood to recover, it might be the size of the claim, but it's really where the value of predictive analytics comes into play is you can build a sort of a multifaceted model to make this identification. Were identified as lowest priority. So this really helped the Christus team understand how to leverage those resources, apply the highest touch to the highest return on investment, and optimize their business process to bring that DSO down and do it in a way that maximized revenue back to the organization. So I'll just sum it up and pass it over to Steve. Again, this is predictive analytics are coming. They're here today. From the data that we've conducted and the research we've conducted, it's happening today. It's happening across the organizations. And so thinking about the resources that you bring together, cross-disciplinary teams coming in to support this, and then I think with the use cases we've showed, really choosing the right places to start that make sense for the organization, and the value can clearly be articulated in either dollars or other metrics that are core to what the organization is trying to accomplish is really critical to getting these programs off the ground and started successfully. So with that, Steve, I'll pass it over. Hopefully I think we've got a good amount of time here left and for questions, and I'll be back on at the end to engage in Q&A with the audience.
Great. Thank you, Andy. What I was hoping to do today from our perspective was share sort of tips about how to utilize predictive solutions for real impact. In some sense, it's sort of the plumbing and the operationalizing behind the stories that Andy just shared, and also to give people, and this is a financial community, give people a sense of sort of the types of use cases that are out there. Some of them are obvious, some of them are more subtle, but again, kind of flip through some ideas that are going through the market for you all to kind of think of them as brainstorms and framing. So everything, when we talk about this stuff, everyone thinks about predictive analytics, think about models. They think about the ability to create a score that looks at the future events and what's likely or possible to happen. And while a model is a critical piece of the solution, it's not the only piece of the solution about creating value. And Andy said this earlier, it is about converting this model or prediction into workflow, because you have to leverage the insight to kind of treat the account, the patient, the claim differentially. And so we think of this, and I think the use cases are all saying this, which is sort of, there's a prediction, a predictive model about what's likely to happen. It's focused on a point in a process or relationship where there's great uncertainty. of what's going to happen. That prediction is then used to kind of take an account, the patient, the claim, and assign it into a segment. And the segments, by definition, are supposed to have similar needs and similar issues. And then you can design a specific workflow to that segment so that you kind of respond to the specific issue that the group needs to kind of move forward. And then you have multiple segments. Each segment has unique experience, and then you kind of use dashboards and reporting to understand how we're doing in each segment and overall. And effectively, you want to be measuring the segment level performance. Is it performing as we expected? And is this segment performing differently than the other segments? Because segments should be homogeneous to themselves and distinct from the others. And over time, using the information around the process and performance to continue to refine the model. This is a process. This is a learning journey. You deploy a model, you build the segments, you get the workflow, you execute, and then you track, and then you modify. I made a point earlier about models and the kind of a good predictive model and kind of applying in the right spot. A predictive model, the application of needs to focus on this point of uncertainty. And the example I often give here is I can make a perfect model that guarantees that is 100% correct. The sun will come up tomorrow. I guarantee it. That prediction has very little value because there's very little uncertainty in it. So again, the focus has to be to find places where there's uncertainty about what's likely to happen. And then the prediction has value because the prediction starts telling you within the range of uncertain events, what's more or less likely to happen. So let me give you some examples of places where uncertainty occurs and how models can actually play out for value. There's one that in the financial realm has kind of become very traditional, very well accepted. So this idea of propensity to pay, patient payment segmentation, whether you're uninsured accounts or balance after insurance accounts. I get thousands of these flowing into my health system. How do I think about engaging patients to resolve the bills? This is a framework that we at Connance believe, which is about, that's not only about, quote, propensity to pay, which is sort of what's the likelihood of getting paid. We actually think that in the business of healthcare, we worry about expected cash value, and we think about the cost to collect or the cost to convert. And so as the segmentation logic on the left shows, this is sort of a way to think about using propensity to pay analytics for a slightly different kind of more workflow-driven approach to the problem. So I have the lower left where I've got low expected cash value, so the actual value of the account. Think of this as propensity to pay times the balance due times the percent and get collected. So all the way through to the kind of dollars and cents that we're going to get in our checking accounts. The lower left is sort of not worth a lot going forward, and it also means that the patient's unlikely to sort of engage. They're going to be a reluctant payer. This is sort of segment one you want to conserve here. And the grid on the right shows you sort of the economics of the various numbers on the left. So segment one, 20% of the accounts in this portfolio, it's 1% of collections at the $7 unit yield. It's a lot of, you can't spend a lot to collect $7 from an account. And finding the 6% of accounts inside the 20% is very hard. Segments two and four, that's 38% of the accounts. But look down low, the percentage of accounts paying, 75% of them are going to pay something. Collection rates are north of 70%. This is a place where the logic would say, these are engaged patients. By and large, we can actually get them to self-resolve using portals and text messaging and do-it-yourself solutions. Segment 5 is sort of high value. It's a place where our customer service reps can have more leverage in talking to our patients. And if you listen to the way I'm articulating this, you're starting to hear me talk about workflow to the segment. And that's really intentional. You think about the analytics to create segments. The segments have different characteristics, therefore allow us to have different workflow. There's a related analytic you can put around this. This is sort of in the realm of not so common. So a lot of systems in the industry use, they do eligibility pings. They kind of reach out electronically to check the Medicare, Medicaid, or the payer kind of membership roles, and they confirm somebody's coverage. Well, what we also know is that in the world of patient balances, a significant portion of insurance is discovered well after service is delivered, and effectively actually later in the process than you think, because what happens is, lo and behold, the patient calls up at 2 days before assignment to bad debt and says, "Oh my God, I didn't know you were looking for insurance. I have insurance. Somehow or other, this slipped my attention. Let me give you my insurance card." A significant portion of self-pay recoveries actually is from late-stage discovered insurance. There's an analytic it's called, think of it as predictive insurance flag. So it says this person claims not to have, the information says they don't have insurance. We've gone to the Medicaid or Medicare or Blue Cross membership panels, and they come back negative. But for all of the statistics, it looks like this person should have insurance. And so let's change the scripting of our customer service reps with a blast message to say, "Hey, we think you have insurance. Can you call in so we can just test our thesis?" And effectively, you can see here, the group one, this is 57% of accounts in the portfolio. 90% of the payments in this group will come from found insurance. Of all the found insurance in the portfolio, this group will be 75% of it. It's 10% of the accounts. So it's 10% of these accounts. 57% of them will make a payment, and 90% of that payment will come from insurance. So from a scripting perspective, we know that the first message to these people needs to be, "Hey, we're calling because we think you have insurance, but we're not able to figure it out." Again, workflow. We can convert that insight to workflow. Another common model. How do we know that people living in poverty or meriting financial assistance are sometimes either embarrassed by their situation, or for some other reason they're kind of not engaging. They're not proactive in their effort. There are analytics out there to identify people living in poverty. Typically speaking, if you're not using some predictive analytic, about 30% of your bad debt assignments are probably people that merit financial assistance, according to standard, financial guidelines and charity guidelines. There's some analytics you can use that will look at both the uninsured as well as the balance after insurance and evaluate them according to your guidelines, IRS Form 990 rules, etc. Better ones tend to focus on this question of, are you living in poverty, as opposed to trying to predict household income. It's usually the better solution, sort of triangulate using 2 or 3 different screens. The first screen being kind of attributes suggest you're living in poverty. Then it's sort of confirmatory with the, based on the error rate or the kind of income guesstimates we're making, the range of the unknown on the income confirms that this is likely living in poverty. It turns out it's very, very hard to predict income accurately at the gradations that we need for financial assistance. And so the better ones are going to focus on this idea of identifying poverty and then confirming with income. And these sorts of analytics can put to work early for eligibility or late for bad debt scrubbing. Again, think workflow. Another workflow analytic that's out there, which is sort of in its emerging space, payment plans are a significant portion of the kind of solution or path forward with high deductible health plans. We've got people that have insurance, but they still have $1,000 or $2,000 kind of payment responsibility. That's too big to pay with a single check, and so payment plans have become sort of a kind of a critical lever for organizations. The problem is that, particularly in some of the hospital and ambulatory settings where the bills tend to be larger, the fixed design strategies, take the balance, divide it by 10, or take the balance, divide it by 12, they tend to have a pretty high delinquency rate. They, upwards of oftentimes 40% or so after a couple of cycles will go delinquent. This delinquency issue is less significant when the balances are smaller, a couple $100. You don't see the same thing, but when they start getting over a couple $100, the delinquency rates go up. It's also a source of sort of a black hole in process routinely. When they go delinquent, it can be often very hard for business offices to figure out who's delinquent and where they are and who has them and how to keep them moving. So you find a lot of accounts that go delinquent sort of disappear into a black hole in our processes. There's some analytics out there that look at the patient's context, the balance they owe, and will kind of frame the ideal or highest expected value payment plan. And if they do it right, they'll basically offer the first highest value payment plan, that being the payment plan that has the highest expected present value to the hospital, but that the patient won't go delinquent against. It offers the patient that. Some of the more slick solutions out there, if the patient doesn't take option 1, it will give them a choice of option 2 or option 3. So we'll step them through a series of offers. And again, the idea here is to help make a prediction about the future and then optimize the way we engage. I'm going to change out of the financial realm quickly and try and, again, open people's minds to where some of these predictive analytics can help them workflow. A growing space around patients and healthcare is social determinants of health and understanding the factors outside of the exam room, off the campus. And it turns out that upwards of 70% of an individual's health is not clinical, but deals with some of these other factors, safety and activity and transportation and access to food, etc. Much of the information is not really in Epic in a sortable way. It's not in sort of it's not available before the patient ever arrives, and so we find ourselves as clinicians and dealing with readmissions, for example, find ourselves guessing what's going to happen when the patient goes home. Turns out that a lot of the social determinants are predictable. You can kind of identify the name. You can take the address and kind of understand the context that person and their family lives in outside of the hospital or the exam room. And that insight can help you kind of identify social determinant risks or issues. And those issues can be married up with clinical measures, clinical analytics, to give you a richer view of how to manage readmissions. And this is a client study where the vertical is the clinical risk. So the highest 20% is the top row, the low clinical risk, the bottom row. If you look at only on clinical risk, you kind of have one lens of it all, and you would see the top row only. When you look at the social determinant measures and say, look, there is a bunch of people who have very low social determinant risks on the left, and there's some that have very high risk. And think of this as transportation challenges, nutrition, food access challenges, home instability, health literacy issues, health comprehension issues. On the right, lo and behold, you discover that the high social determinant risk and the high clinical risk, the upper right, that group has about 36% readmission rate. So 1 in 3 is going to readmit, left without intervention, if you will. What's interesting is that the second highest risk spot on this matrix is actually not the middle top row. It's not high clinical risk, medium social determinant risk. It is, in fact, low clinical risk, but high social determinant risk. And that is actually the second most complicated space. And this is sort of the hidden risk, which traditional clinical architectures and clinical solutions miss, because it's not available in the EMR on a systematic basis. It's not gathered. What's interesting about this kind of architecture is a lot of the social determinant issues can be known well before the patient actually shows up in the room. So if you've got 1,000 members in a risk pool, say an ACO or something else, you can start stratifying that population on their social determinant risk to identify those people who are on the right. Now, you don't know per se that they have clinical issues yet, but you do know that if they have clinical issues, they're going to be complicated. Or if you can do things to keep them out of having clinical issues, you're actually going to be able to manage the risk pool better. The other way to operationalize this around the industry is things like a lot of people have post-discharge follow-up resources, and some of those post-discharge follow-up things are phone calls. Some of them are home health visits. Well, this sort of risk matrix can help you identify which ones get the home health visits as opposed to just a follow-up call. When you do this stuff right, whether it's the financials or the readmission stuff, it has a significant impact and significant ROI. Because what you're really doing is you're using predictive analytics to optimize the available resources, the teams, the systems that exist, whether you can think of it as technology like Epic, you can also think of it like customer service reps and people on phones and letters and outbound. So you can use this insight to drive kind of optimized allocation of a very large investment. This is just a very simple example. It's somebody that was doing a patient pay engagement. They were actually utilizing a pretty traditional approach, which is uninsured and balance after, and then they stratified by size, small, medium, and large. They went down that kind of the approach earlier identified, which was more around what's the expected cash value and what's the patient's engagement strategy going to look like. And again, the dark blue in this is where they sort of wanted to invest their high value, kind of high talent people to engage in patient resolution. The top two kind of brighter blues were a place where they wanted the patients to self-resolve. And the lower left is a place where they wanted to kind of manage out their investment. The interesting thing about this story is by kind of thinking differently about the segments, applying the resources and capabilities differentially. Think about email messages and blast messages as opposed to attended dialer calls, letters, and messaging. They were able to see almost a 30%, actually over a 30% year-over-year improvement in dollars collected per account. So their unit yield had a significant uptick. But at the same time, they also saw a 44% reduction in call volume. They were able to call fewer people and receive fewer inbound calls because they targeted their engagement approach to the patients. They were able to reduce their letters and postage 34%, and ultimately they were able to restructure their staffing by about 10 or 12%. So the combination of this was not only to realize more money, but to do it at a much lower cost. Very high ROI. As I sort of wrap up and we get back to sort of, I think some of the open questions and your questions, Andy and I thought it might be helpful to kind of provide something of a checklist for folks as they think about where to go and how to think about applying predictive data in a differential way. It does start with the right analytics in the right spot. So you have to understand you have to think carefully about where you're trying to apply this information and how you're going to, what question you're really answering, right? So if I go back to my propensity to pay conversation, do you really want to know who's likely to pay, or do you want to know who's worth the most amount of money? And not all propensity to pay is sort of an interesting one because there are different models out there. Some propensity to pay models are actually answering the question of what's the propensity to pay more than $25, as opposed to what's the propensity to pay if the bill is $1,000. So some models may or may not take into account the balance and the upside. You should think carefully about what data goes into the various models. If you're building your own models or buying third-party models, it's important to understand sort of what's going in it. And the reason for that is because you want to know, does it take in prior experience? It's a popular question. So if you're using a third party, are they going to somehow or other integrate your localized experience into their analytics? Is there credit data if it's consumer oriented? Again, you want to know about FCRA and various things around consumer watchdogs and views of credit data. What clinical data is necessary? If you need a lot of data, will we have all the data where we're trying to apply it? If you're looking for a deep clinical model, that means you need a rich clinical file. So if the patient hasn't come in yet, if you've never seen them, you won't have the clinical data, so you can't apply it in that context. Is the model really answering some of its uncertainty? A point where there's leverage. Remember my simple example of predicting the sun comes up tomorrow. Understand, is it going to be able to address all of the population you're interested in? Is it going to be only the people outpatient, only people inpatient? Is it only people that have credit files or don't have credit files? Make sure you've got coverage. And then if in fact I have the right model, will the insight be able to convert into kind of assignment logic? And that takes me to the second group, which is sort of workflow. Think about what your capabilities are. What do you have internally and externally? And then think about the segment and the insight. And ideally, the analytics are kind of putting people into segments, and segments have unique needs that you can start to create strategies for what you want to do in each workflow. Again, back to my, if I go back to the readmission conversation, you could say that, look, the high social determinant risk, but lower clinical risk, that's a group where I need a home visit with a skilled person to think about how to help the social determinant issues. That's a different visit than the person who has a high clinical risk, but not so high social determinant risk. That may be more of a clinical type kind of home visit person. So you can start thinking about which kind of resource to which kind of segment. And you want to be testing it the reverse, which is if I was this patient, or I was, if I was this patient, would I feel the strategy? Would I sense a different experience? And then ultimately, you want to go live. You want to put it in deployment, and then you want to think about measuring impact. And you want to measure both the input activities and the output. It's always great to think about I like the cookies I baked, and you after you bake them, you're like, boy, these cookies were delicious. But you say, are they as good as the cookies did last week? No, last week's were better. Well, what was different about last week's cookie? You had to know what the recipe in was. And so we're very focused on this question of understanding not only the outcomes, but also the inputs. What is the process? What activities occurred? And then tracking those over time to start kind of mapping segment activities and segment definition to output. And you are thinking about both. Does the segmentation work? And is the workflow in each segment effective? And they're separate questions. So with that, hopefully Andy is still on the phone. We had a couple of questions that he and I kind of have heard around a lot, and I thought it might be interesting to Andy can share some of his thoughts, and I'm happy to share mine. One of the ones, and I'll start. Andy can start actually because he's more interested than I am. One of the things we hear a lot about, Andy, is sort of the, I want to do predictive analytics and prescriptive analytics. Do I need a big platform, or is this a big endeavor, or can I go with small targeted things? I mean, this sort of this kind of constant debate around.
Right. Yeah, and it can be, it can be paralyzing to some extent, right? If depending on kind of who you're talking to and when looking at, we see this sometimes kind of stop folks in their tracks from getting started because the scope is so broad, or we need the sort of the ultimate platform in place today. I think it's a lot of it, and Steve, you brought this up in the last slide, which is great, which I think part of it comes down to understanding the capabilities of your organization, and depending on sort of the use cases that you see, how those tie to and the workflow, really importantly, how that all ties back to the core capabilities and how your organization delivers value for customers. There's going to be a lot of times these types of solutions, there's the technology investment to make it possible, and then there's the ongoing investment in the people and the process to keep it all current and to keep it activated. And that's where, I think a lot of times some of the ROI models and investment sort of criteria break down a little bit, is really underestimating the amount of time it takes to keep it current. I think another, really important thing to think about is, a big platform that, and this touches a little bit on the second question as well, but, building your own and running your own platform, could be great at a certain scale. There's a question, especially with predictive analytics, on, how large is your historical data set that you can build your models off of. So, there's probably no right answer, between the two, but certainly, having a big platform isn't the only answer. And there's definitely cases where, multiple targeted solutions, especially for specific use cases, can make a lot of sense, because, not only do you get kind of a really focused solution on a particular problem, but you get the ability to leverage some of the skills and expertise of a partner that you might work with that's very, very deep in that particular area, that brings a lot of subject matter expertise, potentially brings in some outside data to help augment the data that you have in your own organization, and can really deliver a custom kind of tailored feeling solution based on their understanding. So what have you heard, Steve? What are your thoughts on that?
It's funny you mentioning something, because there's a question that's come in the queue around pooled or custom models. Our experience says that you can get the paralysis of a big platform is absolutely the case. And the installation of a big platform and the overlay systems can be huge and very long time frame. The challenge you get as you work through all of this big platform deployment is you lose the experience of exercising and practicing. Using these models, this idea of segmentation and workflow and process measurement and improvement, the practice of working it is a big deal. People, generally speaking, start slow and pick up steam. And so, because it's a different mindset, there's a flexibility, there's a learning cycle. So our experience, we've seen people that actually kind of get on both paths at once, which is sure, the big thing is a good thing, but don't wait. Get moving, create value, wins are wins, which is part of where this pooled versus custom score comes in, and it's buy versus build, I think, which is, we find lots of people, lots of health systems have, I have 10 hospitals or 15 hospitals, and I've got regional density. I've got, I'm a big hospital. Can't I just build my own score? What's interesting in that conversation is yeah, you can conceptually build a predictive model for your own experience. The challenge you run into is, first off, if the world changes and dynamics in your environment change, your model may not actually be ready for it because you may not have that in the experience set. And so I'm here in Boston. I think it's all the time, which is we've never seen a kind of a manufacturing industrial cycle similar to what Detroit has seen in some of the Great Lakes around the auto cycles. But if and when the kind of F-35 fighter pilot program goes away, the huge portion of what is now kind of an industrial complex in Massachusetts is going to find itself on the wrong side of that trade. And data out here would never have seen that before. And so understanding what happens in that environment, if someone is building a custom model in New England, they'd have a tough time having that data in the sample to train their models. So you said this earlier about this kind of if you have the right partner, you can find somebody who can help you kind of bring different data, bring experience to kind of compare and contrast with the internal stuff. So part one is sort of the access to data, and this partner thing is a big part of the value. The second thing is it's really hard. Models, predictive analytics need to be maintained. There's an investment to build them, there's an investment to maintain them over time. You want to keep refining and keep developing. In the kind of the really tight budget challenges of healthcare systems, it's pretty hard ultimately to maintain the scope and scale of organizational talent and resources necessary to really do that soup to nuts. And so it's oftentimes perhaps better for the health systems to focus on the deployment expertise as opposed to the modeling side, and to be a partner with this external resource so that they know that, they're learning how to exercise over time, but not finding themselves spending all their time trying to figure out the models still current. And this sort of is part of that buy versus build, and sort of this question around pooled data versus custom. There is real power in a pooled model that is sort of configured to your local deployment. You want to talk about the last one there?
Yeah, I was just going to say to back that up, Steve. I think we see a lot of organizations take kind of a hybrid approach with the partnering with the specialist and then building their own, and it gets back to some of the points that you talked about, which is some of the use cases that the organization identifies are going to be use cases that are really well aligned with the majority of the way that organization derives value for its patients or its customers. And so in that case, they may say, look at this and say, hey, this is really core to our business. The investments that we make in building out these models, might open up new business opportunities, might open up new service lines for us as an organization. So we're going to go ahead and build those out. But it's, rarely do we see an organization that can tackle all of the great opportunities that predictive analytics present with that core team. You want to keep that team focused on the highest impact. And so that's where, partnering with specialists on those use cases that, could drive significant business value and get integrated into workflow, but, maybe aren't, the kind of the top two, top three or as core to the business can make a lot of sense there as well. So I think for a lot of organizations, like I said, it's going to be sort of a hybrid approach here to doing this. You're going to do a little bit of both building and partnering.
Right. Curious on your thoughts on this question of, I have a question that came in around time to value. So what's your sort of thoughts around time to value and sort of what is the path to time to value? Is there a fast way or a slow way on this? And I think in some way that actually is derivative of this Epic Cerner question and this no bolt-ons, because do you have experience in this time to value about how to think about maximizing time to value?
Well, I think one of the recommendations that we'll make is if someone's new, if an organization's new to implementing predictive analytics, is you want to think about your use cases as a portfolio, and you want a balance of short-term, sort of quick win, maybe a little bit smaller overall, ROI or IRR, but being able to demonstrate the capability and the impact of that program early on, because there's a value case that needs to be made for the upfront investment in the infrastructure and in the team. There's also a lot of work from what we've seen that can go on in terms of getting the organization to sort of buy into this idea of now using predictive analytics to change the workflow. Depending on the sort of the makeup of the organization, you can have folks that have been in their jobs for a long time, have a lot of knowledge about what they do. And so, to kind of come in and say, hey, we're going to rework all this because of data, that can be very successful, but it can take a little bit, of time to do that. And so having some quick wins to show the benefit and making sure those are positioned the right way to sort of win the organization over and say, here's how we're going to be doing things differently and get everyone on board with that can make a lot of sense. And then, that's got to be balanced against some, sort of big, hairy, audacious goal kind of projects a little bit further out that can really sort of build on that momentum and really demonstrate the best of what the program can do. Too many short wins, you get a lot of excitement around it early on, but then you never quite have that, that huge win that tips the organization. Too many long projects, everything's always coming a month out, and, the organization kind of lose steam. So I think it's a balanced approach across the use cases. And when you think about that, how do you think about that, Steve?
And you kind of, this time to value thing is it's all about momentum. And big, hairy projects with large, audacious goals can be long time to value. And so I think your point about, balance it, the portfolio, find some stuff that works, build some wins, get people excited. The extent to which you're working with a partner, get things that work with the partner, make, sort of the trust and relationship in this is not a trivial exercise. So pick people that you're comfortable with and exercise. We're coming up at the top of the hour. I don't want to overstay our welcome with our audience. The only thing I was going to say on this Epic Cerner no bolt-ons, you have it on the screen, was very quickly that it's funny, everyone wants to be inside Epic and inside Cerner, which I think makes a world of sense. It turns out Epic and Cerner actually aren't in the predictive analytics and sort of world. They all seem to have sort of a set of fields where they can ingest outside data and outside analytics. So I think that, we want to be an Epic or a Cerner shop is great. It doesn't preclude that our experience says doesn't preclude people from utilizing, great external kind of predictive data in their workflow. And actually sort of those platforms can be great enablers of good workflow. I won't make you pile on, Andy. It's 2:00. I want to say thank you to you again and Intel for supporting this webinar and kind of the thoughts you've shared. To our audience, thank you very much for your time. If for follow-up, there's my email, and there's Andy. With that, I'm going to wish everybody a great either afternoon or morning, depending on your time zone. And thank you, everybody, for coming.